Assalamu alaikum wa rahmatullahi wa barakatuh. This is Dr. Nuha. I am specialist of Singani from Masana Polyclinic. This lecture is about the vaginal discharge in pregnancy and its management. As you know, most of the women during pregnancy, they will have and complain from vaginal discharge. Most common vaginal discharge is candidiasis, which is known also as thrush infection. So what are the symptoms of candidiasis? Most common symptoms are itching and burning in vagina, pain during sexual intercourse, even burning sensation during urination, and thick vaginal discharge. They will describe it as whitish, cheesy-like material discharge, which is typical for candidiasis. So itching, burning, redness, and white discharge. The most common causes, as we know, it's either due to wet area, maybe they are using or wearing nylon underwear, or sometimes uncontrolled diabetic, sometimes due to poor diet, using like they are eating chocolate or sugar material, containing material. Sometimes antibiotic, for example, if you take history from the patient, she will tell you that she started, for example, antibiotic for UTI or antibiotic for toothache. After that, she developed this vaginal thrush. Also, sometimes due to weakened immune system, which is happen in a pregnancy or in diabetic or other diseases that lead to low immune system. Stress itself can reduce immunity. Also, pregnancy is one of the reasons to increase vaginal candidiasis and hormone like oral contraceptive pill. So the prevention is personal hygiene, less sugar and alcohol, and to increase fruit and vegetable, and avoid nylon underwear and better to use cotton underwear. So what is vulvovaginal candidiasis? The most common causes is Candida albicans, which is 80 to 89%. There are other Candida species, but the most common is Candida albicans. What are the risk factors? As we prescribed in the slide before, either due to diabetic, reduced immunity, endogenous or exogenous estrogen, endogenous estrogen, for example, polycystic ovary syndrome, those women in which there is excess endogenous estrogen. Regarding exogenous estrogen for women who are taking oral contraceptive pill or hormonal replacement therapy. Sometimes due to recent antibiotic use, which lead and cause disturbances in the vaginal pH, as I mentioned in slide before, like taking any antibiotic for UTI or toothache or other reason that antibiotic is needed. The symptom, as we say, is non-offensive vaginal discharge, but vulval itching. Candidiasis means isis means infection, so there will be soreness, burning, superficial dyspareunia, cyclical symptoms. Erythema, fissuring, swelling, oedema. Vaginal discharge typically is non-offensive, and dirty means it looks like cheesy-like material, typical by inspection, but may be thin or absent. And sometimes there is satellite lesion and excoriation mark. As you see here, this is the satellite when you examine the skin. The diagnosis, sometimes we do vaginal swab. It will come like high vaginal swab by using charcoal. It will come like Candida albicans. Sometimes only by clinical diagnosis, just by inspection, you will find like cheesy-like material, typical. So this is enough to start a treatment. What other investigation needed to be done? Other investigation, not recommended routinely, but sometimes we want to know the reason for recurrent vulvovaginal candidiasis. For example, diabetic, we'll do random blood sugar, you will do glycosylated hemoglobin in order to know if she is a diabetic patient. Sometimes iron deficiency anemia, we'll do full blood count or serum ferritin, because as we mentioned, low immunity sometimes happen with low anemia. So we need to do full blood count and serum ferritin. Sorry. Acute vulvovaginal candidiasis, the treatment. So the treatment, we have either acute or severe or recurrent. This is for non-pregnant women, So for acute vulvovaginal candidiasis, for acute, whether she is pregnant or non-pregnant, married or unmarried, we can use fluconazole. Fluconazole capsule, which is 150 milligram a single dose, it's available in our institute. Sometimes it's available as 50 milligrams, so just we will write 150. That's mean she will take 3 capsules together, and single dose is enough. If she is married, we can either give fluconazole or clotrimazole bizarre, 500 milligram as a single dose vaginally. So unmarried, we can give fluconazole capsule 150. If married, we can give either fluconazole or clotrimazole bizarre. What about severe vulvovaginal candidiasis? If severe vulvovaginal candidiasis, that means there is skin excoriation. The patient can't sleep at night because of itching. There is severe burning urination. So you can give fluconazole 150 orally in day 1 and day 4. That means you can give her fluconazole twice, 3 days apart, day 1 and repeated day 4, if severe. What about recurrent? Recurrent vulvogenitis, later I will explain what's mean by recurrent. Here, we will give fluconazole 150 milligram orally, as we say, every 3 days, 3 doses. Then we will give maintenance fluconazole 150 orally once a week for 6 months. So I will give fluconazole every 3 days, 3 doses, 3 tablets, every 3 days, 3 times. So we can say 3, 3, 3, because we have the tablet available in our institute 50. If it's 150, you can give 1 tablet every 3 days for 3 doses. Maintenance, we'll give 1 tablet 1 week for 6 months. This is for recurrent vulvovaginal candidiasis. If non-albicans, sometimes it's come in hypervaginal swab, you can give nystatin bizaris 100,000 intravaginally at night for 12 or 14 consecutive nights. This is if non-albican, you will give her nystatin bizari. But most of the cases, as we say, 80 to 90, 89, it will be Candida albicans. So you use either fluconazole or clotrimazole bizarre. This is very important slide because in pregnancy, the management is completely different. So for acute vulvovaginal candidiasis, that means she got it for first time or in pregnancy, we'll give clotrimazole bizarre 500 vaginally at night, 7 consecutive nights. Please, we'll give for 7 consecutive nights. I know everywhere they are giving 1 tablet or 2 tablets, 1 bizarre or 2 bizarres, but according to the BASH, we must give for 7 consecutive nights. Please avoid fluconazole. Fluconazole is contraindicated in a pregnancy. Fluconazole can be given to non-pregnant women, but do not give it to pregnant women. It's contraindicated. What about recurrent vulvovaginal candidiasis? As we say, recurrent vulvovaginal candidiasis means 4 episodes per year. 2 of them on culture will show candida. So at least 4 episodes per 12 months, with 2 episodes confirmed by microscopy or culture when symptomatic. At least 1 must be by culture. So recurrent vulvovaginal candidiasis. If the woman came to you first month of pregnancy, she has candidiasis, and after 2 months she come again, complain of candidiasis. If you find two of them and two of them show two episodes confirmed by microscopy or culture, one of them culture, so this is recurrent. Maybe in our practice, it is not recurrent vaginal candidiasis. It is due to improper treatment. That means we are giving low dose. That's why they have this recurrent candidiasis, because we must give at least 7 consecutive nights, but we are giving for 1 or 2 nights. So again, for acute vulvovaginal candidiasis, fluconazole is contraindicated. We give Bizarre 500 intravaginally at night for 7 consecutive nights. For recurrent, with that mean at least 4 episodes per year, 2 episodes confirmed by microscopy or culture. When symptomatic, at least 1 must be cultured. Here, we will give topical, means vaginally, we will give vaginally, not orally, fluconazole, because as I repeat it and say, fluconazole not to be given. We'll give topical imidazole or clotrimazole, increase to 10-14 days according to symptomatic response. Here for acute 7 days, but for recurrent we can give for 10 to 14 days according to symptomatic response, and we give maintenance Bizarre 500 weekly till the symptoms disappear. Contact tracing not required, so no need to treat her husband because it is not sexual transmitted disease. Follow up and test of cure only if symptom does not resolve or poor response or partial response to therapy. That means no need for follow-up. That means I will give her treatment until if there is no response, come back. Otherwise, I will not give her appointment for follow-up for this candidiasis. Again, this slide is brief for what I mentioned previously. So if acute, we will give first line fluconazole. Second line is Bizarre. If recurrence, we can give fluconazole, and we say 150 milligram, means 3 tablets if it is 50 milligram, 3 times per week, then weekly for 6 months. If non-candida albicans, we can give nystatin, Bizarre for 14 nights, or boric acid, Bizarre for 14 nights. But this is not applicable in our institute. At most of the cases, as we say, it is candida, so we will focus on these two parts of this chart. But sometimes this is also important in old women, means 40 and above, 40 years and above. Sometimes there is always, she complain of pruritus vulva, even if you give this medication. So sometimes we have to put differential diagnosis, maybe like in sclerosis. This will be explained later in gynecology module. So again, this is very important, as we say here. If acute, non-pregnant, fluconazole 150 or clotrimazole 500. A pregnancy should be given for 7 nights, clotrimazole, Bizarre. This is for acute. If recurrent, non-pregnant, we say 150 every 3 days, 3 doses, and maintenance fluconazole 150, 1 a week for 6 months. Non-pregnant, that's why we can give fluconazole. But in pregnant and recurrent vulvovaginal candidiasis, we will give topical imidazole therapy, can be increased to 10 to 14 days according to symptomatic response, and maintenance clotrimazole Bizarre 500 vaginal weekly. For how long? Till the symptom disappear. For severe vulvovaginal candidiasis, non-pregnant, we will give fluconazole day 1 and repeat it after 3 days. So this is also brief for the previous slide. So, duration of therapy. Longer courses are recommended in pregnancy. A systemic review found that 4-day course will cure just over 50, whereas a 7-day course cured over 90. That's why, according to my practice and my colleague practice, we found that when you give pregnant women clotrimazole suppositories, 1 or 2, they will come back to you with the same symptom, because the treatment, it must be for 7 days. So I hope we will implement this in our practice. For any candidiasis, we'll give clotrimazole 500 milligram for 7 days, as this can cure over 90%. What about bacterial vaginosis? Bacterial vaginosis is most common also infection in pregnancy, can lead to preterm labor. So it's very important to manage bacterial vaginosis. If you just focus on vaginosis, means there's no inflammation. Most of the women, they will have no itching, no inflammation, not like candidiasis. Isis means infection. So etiology, due to that, vaginal flora will be disturbed and will be dominated by many anaerobic Jardinella, Mycoplasma, Mobilingus species, but mostly Jardinella vaginalis is the most common causes of bacterial vaginosis. What are the risk factors? Many women are using vaginal touching, so this should be stopped, and counsel the patient that vaginal touching can change the vaginal flora and precipitate Jardinella vaginalis and bacterial vaginosis. Sometimes happen in black race or recent change of sex partner, smoking, presence of any other sexual transmitted disease like chlamydia or herpes. The most common, they will come to you offensive, fishy smelling vaginal discharge. There is no soreness, no itching, no irritation. As I say, vaginosis, oosis is not inflammation, not like candidiasis or trichomonas vaginalis. So many women, approximately 50%, are asymptomatic, but sometimes during the patient, they have no symptom, but sometimes there's vaginal discharge. So this is bacterial vaginosis. The sign, the thin, white, homogeneous discharge coating the walls of the vagina and vestibule. Bacterial vaginosis is not usually associated with sign of inflammation, as I mentioned this. The diagnosis is EMSLA criteria. Most of the women, they will have thin, white, homogeneous discharge, clue-sealed on microscopy of wet amount, pH vagina more than 4.5, release of fishy odor on adding alkali KOH 10%. So 3 out of these 4 is EMSLA criteria, is typical diagnosis for bacterial vaginosis. Sometimes crime stain vaginal smear will show Jardinella vaginosis. In my practice, if I have one patient pregnant and she has vaginal discharge, that she will describe as offensive vaginal discharge, especially after having sex. Mostly I will write clindamycin vaginal cream, because later I will explain the treatment. It is either Flagyl 400 milligram BID for 5 to 7 days, or metronidazole 2 gram single dose, but the patient will not be able to tolerate 2 gram single dose. I used to give clindamycin cream 2% for 7 days, because this will not affect on her GIT, because metronidazole, many patients couldn't tolerate the metronidazole tablet. And follow-up, a test of cure is not required if symptom resolved. So in bacterial vaginosis, again, most of the patients will have thin, white discharge, no itching, but very offensive smell discharge. I will advise her to avoid any vaginal douching or use any shower gel or antiseptic agent or shampoo in the bath. And the treatment will be Flagyl, which is metronidazole, The medication available in our polyclinic or in institute is 250. So I will give 2 tablets BID for 5 to 7 days, or you can give clindamycin cream, which is OD at night for 7 days. What about Trichomonas vaginalis? It is happen sometime. This is happen through sexual intercourse. So we need to treat the partner also. 10 to 15% asymptomatic, vaginal discharge. There is itching because we say vaginalis. There will be dysuria, offensive odor, low abdominal discomfort, vulval ulceration. So there will be vaginal discharge, thin scanty, profuse, and thick in 70%. Sometimes the patient will give typical that the vaginal discharge is frothy-like. She will tell you like there's frothy urine discharge in 10 to 13%. Vulvitis and vaginitis, strawberry cervix appearance. Again, the treatment here is Flagyl. You can give either 2 gram oral in single dose or 500 PID for 5 to 7 days. So here you will see this is like strawberry cervix if you examine by speculum, and you will find this discharge and these dot like strawberry. And this is the Trichomonas vaginalis itself under microscopy. So contact tracing, yes, and the treatment also need, the patient husband also need to be treated with the Flagyl 500 PID 5 to 7 days. Trichomonas vaginalis itself can lead to preterm delivery, low birth weight, postpartum sepsis. So metronidazole used in all stages of pregnancy. So some question may be, some people may ask whether we can give Flagyl in first trimester. Yes, Flagyl can be given in any trimester during pregnancy. But just regarding the breastfeeding, if using single dose of metronidazole, please just tell the patient to stop and avoid breast lactation at least 12 to 24 hours to reduce infant's exposure. So it's not mean that it's contraindicated in breastfeeding, but it's better to avoid breastfeeding at least 12 hours. So simply she can breastfeed the baby, take the Flagyl, and after 12 hours again start breastfeeding the baby. What about genital herpes? Genital herpes, sometimes it's, we have some patient, pregnant women with herpes. It's very important to know primary herpes or secondary herpes. Primary herpes that the patient for the first time she has it. So here the risk for transmission is 41, while the recurrence is 0.3. So it's very important to take history, whether she has this herpes before or this is the first time or she has it before. So if the first time, please, we must know at what gestational age the pregnant women now. And of course, you can give acyclovir, it's safe in pregnancy. You can give 200 milligram 5 times for 10 days. And or valsiclovir, but we have acyclovir. And of course, the herpes is multidisciplinary team management. That's mean you can advise the women for hygiene, proper hygiene, and refer her to dermatology because it is a multidisciplinary team management. So herpes simplex virus is around 2%, 5.5 to 2% pregnant women have herpes simplex virus. I got 2 patients around per year with herpes simplex virus. One pregnant and one was not pregnant. So if risk of a transmission, as we say, if intrauterine 0.5, perinatal 85, postnatal 10%. So if she has recurrent, that means this is not the first time. The risk for transmission is less, but if it is primary, there is high risk of the transmission. So what about acyclovir? Acyclovir, we say it is safe in pregnancy, can be given safely to the pregnant and breastfeeding women. What about the chlamydia trachomatis? Chlamydia trachomatis also, it is one of sexual transmitted disease. that can happen in pregnant women. They will complain sometimes asymptomatic, sometimes they have vaginal discharge, sometimes postcoital intermenstrual bleeding. Many women, they will come to us, especially in their 20th or 30th of year of age, they will complain of postcoital and intermenstrual bleeding. So we must put in differential diagnosis chlamydia trachomonas. So we'll ask her whether she has any vaginal discharge, whether she has dysuria, lower abdominal pain. Even they have this deep dyspareunia. This is all the symptom of chlamydia trachomatis. The sign, they will have mucopurulent cervicitis with or without contact bleeding, pelvic tenderness, cervical motion tenderness. The complication, if you are not treating chlamydia trachomatis, can lead to pelvic inflammatory disease and tubal blockage and tubal infertility and ectopic pregnancy. What here the diagnosis is by vulvovaginal swab. The treatment is doxycycline, BID 7-day, or azithromycin 1 gram orally, followed by 500 once daily for 2 days. This treatment is for non-pregnant women because doxycycline is contraindicated in pregnant women. So if you have one patient with profuse vaginal discharge and you examine her by speculum and you find on ultrasound there's a free fluid and she has like cervical motion tenderness during doing TV scan, and you find also there is pain and she has also history of postcoital bleeding. So start empirical treatment, but after confirm that she is not pregnant, give her doxycycline 100 PID for 7 days. If it is not available, you can give azithromycin 1 gram single dose, but after that, give 500 for 2 days. So we can give azithromycin 1 gram instead, then 500 OD for 2 days. For pregnant and breastfeeding, doxycycline and we say and ofloxacillin contraindicated, we can give azithromycin 1 gram single dose, then 500 OD for 2 days, or erythromycin 500 milligram OD QID for 7 days, or BID for 14 days. Or I'm giving, for me, sometimes I'm giving amoxil 5 milligram 3 times for 7 days, which is the easiest and safest dose also in a pregnancy. And this is available, and most of the patients can tolerate amoxicillin more than erythromycin. So again, for non-pregnant, give doxycycline BID 7 days or azithromycin 1 gram single dose, then 500 OD for 2 days. If pregnant or breastfeeding, you can give azithromycin 1 gram single dose, followed by 500 OD for 2 days, or erythromycin 500 milligram QID for 7 days or BID 14 days. But it's preferred to give amoxil 500 TID for 7 days. Test of cure, yes, only if she is pregnant, but for other is not recommended. So recommended in pregnant women where poor compliance is suspected and where symptom persists, but it's not recommended for non-pregnant women. Contact tracing and treatment, yes, we need to follow up and treat her partner again also. And also any patient suspected chlamydia, it's better to do HIV test, hepatitis, B screening, and also for her partner. What about gonorrhea? Gonorrhea is also sexual transmitted disease. Sometimes the patient has asymptomatic or they have vaginal discharge, lower abdominal pain. The same like chlamydia, but mostly they will have urethral infection, may persist with dysuria without a urinary frequency. So sometimes you find the patient complain always, she will tell you that she has always urinary tract symptom, always dysuria. But when you send her for urine routine, you find it's normal. So here you will do also complain of mucopurulent endocervical discharge. And also they have sometimes endocervical bleeding. So here the same investigation, we will do the same as in chlamydia. We will do vulvovaginal swab, which is not. And here the treatment will be civitrizone, 1 gram intramuscular, a single dose. This is mostly we are using this regime, or quinolone and tetracycline contraindicated in pregnancy, of course. Spectinomycin 2 gram intramuscular, but it's not available. So mostly we'll give civitrizone 1 gram intramuscular as single dose. And of course, we need to contact the tracing and treat her partner also here. For gonorrhea, always advise the woman test of a cure, while in chlamydia, we say no need only if she is pregnant. Partner notification should be done for all patients, and treatment also for the partners who test positive for gonorrhea. And these are the references that I used for this lecture. Thank you very much for your listening.